So with that said, tonight's webinar, Keeping a Pulse on Your Heart Health, super clever name, thank you, is in recognition of February being American Heart Month. We're pleased to have Dr. Viet Lee join us for this presentation. Dr. Lee is an associate professor of research and a preventative cardiologist PA. He's also an adjunct professor for Rocky Mountain University of Health Professions and has over 20 years of practice experience. He has a bachelor's degree in exercise science athletic training and a master's degree as a physician assistant from the University of Utah School of Medicine. He also holds a Doctor of Medical Science with a concentration in health care professions education from Rocky Mountain University of Health Professions. He co-directs the Preventative Cardiology Clinic and Intermountain Medical Center and serves as a principal and sub-investigator on multiple cardiovascular clinical trials. He is an author and co-author of over 80 abstracts and 50 publications with a focus on lipid therapeutics, patient-centered care, and improved shared decision-making processes. So please welcome Dr. Lee. Turn it over to you.
Thank you. Thank you. So I guess I am the first out of the gate, and so I'll set a low bar for everyone else. So keeping a pulse on your heart health. I think as we move forward, please feel free to journey with me and ask questions as we go along. But here are the objectives. So I just want you to recognize those risk factors that lead to cardiovascular metabolic kidney disease. If you're not familiar with that terminology, or CKM or CKMH health, that's a presidential advisory that came out from the American Heart Association just about a year and a half ago. And it recognizes just all of the different parts that come together for cardiovascular kidney metabolic health. And we wanted to talk about how that relates to our own personal health as academicians and healthcare providers. And I wanted to review that atherosclerotic pathophysiology, kind of the epidemiology of obesity, because that kind of centers us on CKMH, diabetes, kidney disease, metabolic steatosis, so MASH, which used to be non-alcoholic steatohepatitis. And then we'll review the Essential 8 from the American Heart Association. These are those lifestyle changes or the numbers that we have to be aware of that make up a lot of this continuum of cardiovascular kidney metabolic health. And then kind of my side gig is really thinking about wearables and consumer technologies and how we leverage that in taking care of ourselves or with the patients in that community. So I love this teaching in the airplane. I think I'm struck by it always because as first responders or as medical or healthcare or anything like that, often we just kind of rush into what's going on in the scene. But CPR has always told you, like, what's happening in the scene. If someone's down on the ground, is it because they got electrocuted? Where's the wire? Here we have to take care of us first in order to have any semblance of empathy, of health, of the ability to really connect with someone else. And so this is it. Put that mask on first. Make sure your health is utmost and at top bars in terms of that battery. And then we can really give our full attention to others afterwards. And so I'm going to come back to this a few times as we go through this journey together. But, acute coronary syndrome, what is it? Acute versus chronic. I like to use this analogy with my patients as they come in and see me. But, this is angina. This is that physiologically, angina is decreased blood flow from one place to the other. The supply just doesn't meet up with the demand. And then the symptoms, I'm sorry, that's ischemia. Angina is the symptom of whatever that is, right? Ischemia, decreased blood flow. Angina is where you get chest pain, pressure, nausea. You get a little diaphoretic or sweaty. And this is kind of what I tell people, like, it's like a road going somewhere. There's a little bit of traffic. It's still moving, but not very well. And so tempers flare. You might, kind of feel that, and it's symptomatic. Here is non-ST elevation acute coronary syndrome, or what we'd call an NSTEMI, non-ST elevation MI. And it's corked, and it's just about to have some infarct or death of tissue down below. And in fact, maybe that's already started. There's maybe some blood flow, but not enough to get where it needs to. And finally, we've been in this traffic. You might have just been in it before coming to get on this webinar. And maybe that's why, folks aren't on right now, as they're in their cars. So STEMI, ST elevation MI, is this kind of stop of all blood flow, and things are going wrong at the bottom end. No blood flow is going to those tissues. So this is cardiovascular kidney metabolic health in terms of the stages. As you go from left to right, what you find is that there are people in stage 0. These are folks that are already living all the essential 8. They're healthy in most regards, no symptoms, no subclinical disease has been found yet, and certainly no clinical disease. And this is where our focus on primordial prevention, like, before disease happens, is important. Hopefully most of us on here and those listening to this later in recording find themselves in stage 0. But as we'll talk about with epidemiology, especially in the US, many are in stage 1. This is where we're excess dysfunctional adipose tissue, overweight, obesity, and this is where dysfunction begins to occur in hormones, neuroendocrine system, etc. And now you've got this inflammation set up and reactive oxygen species kind of causing all sorts of damage. Stage 2 is where hypertension, high blood pressure exists, where your triglycerides are elevated, where you start to have glucose elevations or even type 2 diabetes, moderate to high risk chronic kidney disease. Then there's that subclinical disease where you might have carotid stenosis, where it's narrowing because of plaque, or that heart starts to look thickened, etc. And of course, then an event can occur in stage 4. So question is where can we really help people be near stage 0 in 1? But if they've gone forward in time, this is the fence or the ambulance, right? If you've not heard that poem, please look it up. But there were a township where there was a cliff and people were getting too close and falling off. And the decision was, well, maybe we'll just pay for the ambulance because we need someone down there. People are getting hurt. And then someone else said, how about a fence? Why not prevent that from occurring? And is it the fence? Is it the ambulance? And I'd say you probably need the ambulance from time to time, but that's really not the optimal answer for risk reduction and prevention of disease. So as we look at the life's essential 8, this is it: nutrition, activity, glucose, weight, cholesterol, blood pressure, no smoking, sleep. Those are the pieces that American Heart Association sees that are within our control to a degree, and the things that we can kind of bend one way or the other to help our cardiovascular, metabolic, kidney health be as optimal as possible. Recognizing that we're a little bit different, people are sensitized a little bit different to some certain foods, and sometimes you just have a genetic predisposition to having certain diseases. So this is 1986 to 2006. And what you'll see on the bottom here is the amount of folks that have obesity to the amount of folks that have obesity here, greater than or equal to 30%. And as you move forward in time, our food is a little bit different. The amount of glucose, the yumminess of our foods have increased, and the food addictions also. And so as we get to the red here, and that was just 2006, there's a large part, 2010, large part of our population that's now 30% or more with a BMI of 30 or more. And, we were heading towards about 50% in 2030, 2035. And perhaps we've made some changes and differences. In particular, GLP-1s have been helpful in this space. Okay, so as we kind of look at this, heart as center, I'm a little biased. It takes a heart to kind of run everything else, but kidneys on this left-hand side and liver on the top right. And it's important to recognize that once you've had chronic kidney disease, where it's no longer functioning and filtrating, as you get to stage 4 or 5, these people, half of them have cardiovascular disease, and it's not dialysis that they end up with. It's a cardiovascular death. Like half of them die from cardiovascular disease and not the kidney disease. And it's driven by kidney disease. As we looked up at liver disease, nearly 50% of patients with type 2 will have metabolic steatotic liver disease or fatty liver disease. So anyone that has a diabetic diagnosis or diagnosis of diabetes, 1 and 2, you just flip that coin and most likely they have MASLD or MASH. And then that prevalence, absent diabetes, the presence of fatty liver disease in folks with a BMI of greater than or equal to 30 is about 50 to up to 90%. Like almost all of them to like half of them, right, will have some type of fatty liver disease. And then over 40% of patients, once they get into this fibrotic and fat deposition in their kidney, or sorry, not the kidney, their liver, 40% of them will have a vascular event, some type of stroke, heart attack, or peripheral arterial disease event. And so all of these kind of roll towards the heart, and it's important to keep each of these organs healthy. And that's why CKMH has become the really the focus of the American Heart Association. So let's come back to us. Let's come back to us, because as academicians, as you've made this PhD journey, as you go to faculty or you're a clinician or what have you, this song is fairly popular in Utah. It's "Give, Said the Little Stream." And the story here is this stream has so much and it wants to give. It teaches, fellow colleagues, it teaches family, community, etc. And it's great until the little stream dried up. And I mean, we could call it what you will. I mean, burnout, whatever. It's forgetting that we have to have the mask on first before we start to reach out to others. Otherwise, you can help others and put masks on, but you're not going to be as effective. And certainly, if you roll down that road of CKMH in a cardiovascular event, then you no longer help anyone. So we have to think about this. Are you aware when your stream is drying up? What does this have to do with heart? It has a lot to do with heart. But you have to think, in the past year or currently, are you overwhelmed? Has everything just hit you all at once? We're kind of past the main part of the pandemic, but illness still occurs. We still have some of these waves of disease that come through. This is the juggle effect, right? You're juggling work, finance, family, everything. And a lot of times you're kind of the caregiver, regardless of which role you think you're holding. You're a caregiver in all the spots that you find yourself in. And it's stressful. It's stressful. So as we kind of think of how do we replenish that stream? Well, little by little, and as you can, right? And hopefully the things that I talk about today will start the faucet, and maybe you can get it to dribble, and as it adds, you can get a little bit of a stream. Perhaps it's enough to fill a cup, and perhaps it's really bringing down the rain and you feel refreshed, or someone's just opened up the outlet and you feel fully in your zen. I hope that you find that. I hope there are times that it's on and you are flowing with all sorts of water that you can fill others' cups. And but that's not as common, and it comes in waves, right? Hopefully you don't give all of your water such that you have nothing left for yourself. So healthy lifestyle, it's something that seems very simple, but are sometimes hard to do. So I kind of like this gift because you're meaning to just do that one thing, and dang it, it didn't quite work out the way you thought it would. So as we kind of come back to life's essential 8, how do we go through this? How do we bring this back into our lives, turn on that tap, get the dribble going so that ultimately we have something to fill our cup, and then we can give back to others? So, excuse me. So again, nutrition, activity, glucose, weight, cholesterol, your blood pressure, not smoking if you don't already. And if you do, please, let's work on quitting. And then sleep. This is the hidden 8, actually. It used to be Life's Simple 7. And then they recognized that sleep just was not given enough playtime in terms of our health. Okay, so lifestyle first and foremost. It's the first thing we should reach for. There are pharmacotherapeutic agents for many things, but without lifestyle, you kind of fall short of quality of life. It's the quality of life, not just how long we live it. When I talk to my patients, I say, look, not to be crass, but death sentence versus, life in prison. And I'd be like, well, I'd like to be alive. And they say, well, that life in prison is actually solitary confinement. And I'd say, no, please no. So we don't want to add life if it's not quality. But here, when we think of lifestyle modifications, don't frame them as work. You've got to work to get your heart healthy. It's part of like, look, quality of life is what will make you happy. Doing exercise is what helps you feel happy. It's quality. It gives back. The more you exercise and are physically active, the more you feel like being physically active. So you can, I don't know what's longer, microwave minute or a treadmill minute. Just this morning I was like, oh my gosh, this is taking forever. And I'm 5 minutes in on the treadmill. But at the same time, if I just lean into it, I'm like, you know what? I wasn't quite able to do this about 3 or 4 years ago. So it's good. And it's given back as I now kind of assistant, I coach my daughter's soccer, and it's fun to do so. So let me just tell you the good news, right? As we kind of look at this physical activity, kind of almost a Kaplan-Meier, it is a Kaplan-Meier curve. So as we kind of look at this, right, this is mortality and the reference is 1, so not good. But if you can kind of reduce your all-cause mortality risk, look down here and see this is MET hours per week. So remember that like 4 or 5 METs is about enough effort to mow the lawn for 20, 30 minutes. Just it depends. My lawn, it's like 6 METs because I've got a huge hill. But if you're doing 5 MET hours a week, look how much and how steep that benefit curve is just in that first 0 to 5 METs. That's massive. And then, of course, optimally, we want you to continue to exercise and increase, etc. But there's so much to be said about just getting up out of the chair. Do that first. And you get so much benefit there, just getting up out of the chair. And then as it gives back and you feel better and you want to do more, that comes naturally. So do the things that are fun to do. Here, exercise. Is it the magic pill? We combined all your medications into one convenient dose. And this guy's looking at it and the doc says, and it's a suppository. So, that's kind of how we look at exercise, either when we're told to or when we try to explain it. And that's not how we go about this. It should not be this like, this horrible thing that's going to make you feel better. No, if it's this horrible thing, it's going to be horrible. But are there benefits? And yes, there are. It's not a magic pill, but it's close in terms of quality of life and some of the things here that you have benefit for. Really, just even 10 minutes of a brisk walk reduces mortality by up to 15%. As you saw in that physical activity Kaplan-Meier curve, it does contribute to lowering dementia and depression risk. It does reduce incident osteoarthritis by up to 83%, I guess. Of course, people will debate running and knees and stuff like that, and I'll let y'all debate that. But honestly, exercise, physical activity really gives back to us. So you can do it many different ways. I love this GIF. It's fun because, oh yeah, I guess I could do a lot of different body weight exercises. There are 48 here. Some of them are with cables, some of them with dumbbells, but a lot of them are also body weight exercises. In my cardiovascular research floor, just below my clinic, all of my study coordinators know that just randomly throughout the day, if I'm at my desk and not up in clinic, I will just shout out, let's do push-ups. And it's known that you can just do as many as you need to or want to or are able to, but I will always do 30 push-ups. And in that time, if I finish first, I will just do a plank until everyone's done. And then we congratulate each other and do a wall sit for a minute. And that's just every day we do it. And it's fun to hear people go, wow, I was kind of embarrassed and I was only able to do 3. Now I'm up to 15. It's awesome. And I tell them, do it however you can. And many of them do it modified initially, and then they move on to a more standard push-up. So it can be done. But no matter the desire knowledge, it still takes motivation. There is motivation required. You just have to, it's the old Nike commercial, just do it. But it's fun to do it with friends. And so I try to make it as fun as possible. I go down, and it's funny because sometimes I'll come in down and I'll say 30 push-ups. And they said, no, we did it already. We didn't know when you would come down. And I'm like, yes, slow clap. We are there. They have the motivation, and they do it for each other. It's not like, well, there's no peer pressure, because some of our coordinators like, nah, I don't want to do it. And then sometimes they jump in, sometimes they don't. So it's fun. Okay, so as we kind of think about making it fun, these are the do's. Make it fun. Share it. Do it with friends and family. Schedule it even. I wish I could schedule it. I'm all over the place in terms of when I'm in office, when I'm in clinic, etc. So it's not the randomness kind of works, I guess, for me, but spontaneous moments. But start small. I don't force anyone to do it. I don't tell them to do 30. I just, just join us, whatever. If you do one, you do one. We'll clap for you. And any activity is a win. So start where you are. When you get to 80, 85, I'm hoping I'm this guy. I'm like, throw those crutches. Let's do this. We have to start somewhere. And we're not 20 years old. I'm not. I'm like 30 years from 20 years old. And then but you have to start somewhere. You have to start somewhere. So I love these little girls. I'm going to wait till the gift goes, because this is just hilarious. I love sparring, by the way, but I don't do it anymore. So, but don't. These are the don'ts. Don't feel like you have to do this. Don't crush yourself. Don't wait until you have the time. You will never have the time because you'll just psych yourself out. Don't go all out. These extreme workouts here, not so good. Don't do crazy things. You don't want an injury. The key is to have fun and be able to do more things, not to injure yourself. So don't improvise too much. Bad things happen when you decide to get too clever. Certainly, if you're going to do push-ups, don't do it on unstable surfaces. Okay. Okay. So nutrition, let's move on to that. It can feel complicated. I think we overthink this, and I will apologize in advance to my nutrition science colleagues, because nutrition is the nutrition science has some quotation marks on it. It's very difficult. And I know I'm biased as a clinical trialist with pharmacotherapeutics, but just ad lib is truly ad lib. It's really hard to do surveys and really capture what people are truly ingesting. That's why you need to take, if you'll excuse the pun, with a grain of salt, any of these observational trials that are asking about diet sodas, asking about this, eggs. This is why we have this flip-flop all over the place. But you can't even afford eggs right now, so who cares? But these are the problems with nutrition science, is you just cannot control the variables very well. But in the end, we know what the macronutrients should do and how they should interact, but how they interact is a little bit different once we've ingested it. And of course, everyone's set up a little bit different in terms of their neuroendocrine system too. But I think in the end, if you look at the trials that have been done, the DASH diet has been clinically randomized for folks to, that's dietary approaches to stop hypertension or lower it. The Mediterranean diet, as best they could, they randomized and followed that forward 4 or 5 years. And we saw a decrease in events in those on the Mediterranean diet versus not. But remember, it was about a quart a week of olive oil and then a cup a week of tree nuts, right? So, but just know that if you're looking for general recommendations, that's kind of where we'd go. But simply stated, just eat more of the things that are grown out of the ground. I tell my patients, be plant forward. So 75% of this plate really should look like things grown out of the ground, and fries don't count. You can have some, just they're not the vegetables. So, then lean proteins and low fat dairy, and then just eat less trans fats, etc., saturated fats and sugars. Okay, so the good life can be too sweet. From left to right here in that first green column, this is where we use biomarkers like A1C, fasting blood glucose, oral glucose tolerance testing, etc., and see how your body specifically responds to these things. And of course, to the far right is the diagnostic standards for diabetes. But it's not like it suddenly turns on and it's diabetes. This is a continuum, folks. So anywhere along this line, you can start to have metabolic syndrome. You can start to have insulin resistance, impaired fasting glucose. Those are the things that can happen. Okay. So I would say, okay, people ask me all the time, should we be continuous monitoring? Should we have these CGMs? There is now a direct to consumer device. That's what this is right here. Of course, there's, diabetic, FDA approved medical grade type devices that we prescribe. This doesn't need a prescription. You can order it. It's not gimmicky, actually. Folks, data helps. Data helps. That's one of the problems with nutrition science. But here, you're N of one, you have your own data, you're watching as whatever you eat affects your glucose, and you get to know personally what spikes it, what doesn't, what levels that out, what combinations really flatten that curve for glucose spikes. So yeah, in diabetes, it makes sense. In pre-diabetes or at risk, it's reasonable. For weight management, maybe. I've seen people have success with this, but I think by and large, it might be a little bit too much right now until we really figure this out. Athletic performance, probably not. General public, again, not sure. I'm a clinical trialist, so I need some data. But it is available now, and over the counter is an option, meaning it still is on the other side of that pharmacy counter, but you can buy it without a prescription. So let's look at weight, because BMI is such a clunky way of going about telling a weight story. It tells a story, and in epidemiology and public health, it's a fairly good story of like guessing who's probably at risk. That's why the CKMH stages has BMI in it. But I would say, back in the day, I used this, and I would say, look, I'm 5'3", and at some point in time, I was 175 pounds. And that put me at a BMI of 31. Now, it's a little bit different as I'm Asian ethnicity. And so the BMI for obesity for Asians is 27, or at least starts at 27. For other groups, it's 30. Fast forward here over the past 4 or 5 months, and I will say I'm diabetic, and so I've been on medications to help me to control for that, and now I'm at 152. So my BMI is still in that obese range, and I still need chronic therapy for this, but I feel so much better, even having moved those 5 points or 4 points down from a BMI 31 down to 27. And certainly my glucose shows that, and my activity level also shows that. So I think a little bit more precise or individualized is the waist to hip ratio, this apple pear kind of thing. When we think of apple, why is that at risk? Why is that at risk? Is because that adiposity in that gut area is probably not external adiposity as it is in someone that has pear shape. This is on the hips. This is outside of the abdominal cavity. But in apple-shaped individuals, this is fat around the organs, which will definitely disrupt the transport of hormones and interactions with those organs. And so that's why you get that insulin resistance and diabetes and reactive oxygen species and etc. So it does make a difference, the apple versus pear. So BMI, that's 30 with pear-shaped, it sure, could they lose weight and have weight management? Yes. But the person that's even more at risk is the apple-shaped person with a BMI of 30. So lipids, it always surprises me. Well, no, it doesn't surprise me anymore. But initially it surprised me when I used to start the conversation with my patients, like, what's physiologic normal LDL cholesterol? And if they were aware, they would go, oh, it's, 100 to less than 130. But physiologic normal is actually 20 to 40. We've kind of moved it up because we are different people than our hunter-gatherer, ancestors. I can hunt and gather right now to my pantry, which is like 30 feet away. I'm not waiting weeks to, take down bison or whatever. So it's ratcheted up, but we have not evolved as quickly as we have access to foods. Okay. But anyways, you can kind of see the differences here in where lipids are. I tend to treat people here and above that have familial hypercholesterolemia, which is an entirely different process altogether. But because the potential exists for crashes, so that car story that I started out with, and congestion and traffic accident, things kind of stop. That's atherosclerosis. So this thing again, where we think of all this plaque that's starting to build up within the artery, because that potential exists, we think of posting speed limits, right? So this is like the number of LDL cholesterol, or the amount that we reduce it by. And let me just connect the dots, because you're like, that still doesn't make a lot of sense. All of these things right here in the street, think of that as LDL cholesterol. They're cars on the road. And the more cars you have, then the probability increases for car accidents, for any type of accident. And so that's why we focus on LDL cholesterol, because it happens to be the lipoprotein that can get underneath the single cell layer of endothelium. It seeds back here and interacts with macrophages and foam cells, and it starts to crystallize back behind there. So if we can reduce the amount of cars on the road, then the probability reduces that you have atherosclerotic progression, or that those plaques rupture. Okay. So we target these LDL levels appropriately. You don't have to memorize this. I just want you to know that, again, physiologic normal is 20 to 40. And then we look at LDL cholesterol levels from 100 to 130 as okay. But if you're at risk, you have diabetes or familial hypercholesterolemia, or you have this 10-year risk score of 7.5% or more of having an event, we try to get less cars on the road, less than 100. But if you have had an event, a heart attack or stroke, we try to reduce that even more to less than 70. What if you have more than one event? It's like, oh, we didn't learn the first time, so you're just going to have another stroke or a heart attack. So maybe we should be a little bit better at posting these speed limit signs. We reduce the cars even more. And even then, we're not even close to physiologic normal if we just shoot for slightly less than 55. Okay. So how do we do that? Pharmacotherapeutics. These are the different lipid-lowering drugs, and kind of the cost here down to this point where it's like $20,000 a month. And it's a 1-hour infusion. Yes, I have some patients on that, but they have familial hypercholesterolemia. But it adds up, and it's not the only disease that a lot of people have. You might end up with triple lipid-lowering therapy here. That's 3 meds. But they might have high blood pressure with 2 or 3 more meds. And then maybe they have diabetes with 2 or 3 more meds. And suddenly you look like this, and the cost is high. So, maybe that $15 a month to gym membership doesn't sound like that much when you consider it's $8 a month between these 2 generics. And then it's about $308 a month for these 3 meds. If you happen to have cholesterol. Now, that's not quite fair, because people who do have high cholesterol, it's not always because they're overweight. Actually, it's mostly not because they're overweight. There are other things going on. But, I just making the analogy that sometimes we get kind of mixed up in where the dollars make sense. Here, I would say if you're like leaving money for retirement, it hurts to say, well, I'm going to put 15% aside. It feels like it hurts, but boy, you're feeling good having that money in retirement and going, yes, I don't have to worry about this. So it kind of hurts up front. But the nice thing about exercise is you can feel good at the time. You can enjoy that retirement money now with good quality of life. And then you can have good health also at the other end. So it's the gift that keeps giving and gives long term. So as we kind of think of food, this is vegetarian, is plant forward, or I have to admit, I love looking at the side on the right. That's my food. It speaks to me, but I also love looking at the food on the left. That speaks to me too. As I've gone through this, health journey, I go, yeah, actually, if you put these two in front of me, I would actually choose the left side now. Whereas before I was like, yeah, give me meat and potatoes, fried potatoes, all the time. So let's look at this though. What does a plant forward diet do for you? And this was a meta-analysis looking at multiple studies and research that had been completed. I mean, there's like 8,000, and then they removed, duplicates. So there were 8,385 after duplicates were removed, and then records screened, and then excluded nearly 8,000, and then they reviewed 239, and ultimately got down to like, okay, these were quality ones, about 50 of them, and 19 were clinical trials, 30 were observational studies. But what did they find? Here, if you look at its LDL cholesterol as the outcome and the difference in terms of percentages or means, and you can see that here's the unity, well, yeah, the line 0, it's not a unity line per se, but from 0, where you're making any change one way or the other, you can see that, yes, a plant forward diet, whether it's in these are all observational studies, by the way. This was the 30 observational studies. And yes, it's observed that LDL cholesterol will lower with a plant-based diet. And then in a clinical trial standpoint, these were folks that were 19 studies that were reviewed. And yeah, it's not a lot, but when you implement a plant-based diet and you watch them and you're, making sure that they're on it, you will have some reduction in LDL cholesterol. The other part too is that you're like, well, what happens with HDL? This so-called good, please don't call it good. It's just, it does its thing. But does it reduce improve HDL? It does not. So LDL cholesterol lowers, total cholesterol lowers, HDL cholesterol lowers. It has nothing to do with it doing bad things to you. It's this complicated process of how lipoproteins are made. And I made this comment up here. So yes, it lowers LDL, it lowers quote unquote good HDL cholesterol. But if I see you and you say that, you might get slapped. It's not really good. What we found is that a therapeutic agent that was infusing HDL also did not show any benefit. The CTEP inhibitor trials also did not show any benefit when you focus on HDL. And that was like increasing it by almost 150%. Still no benefit when you do that. So, these suggest HDL may be meh. It just is. When it's low, it's a marker of bad. When it's super high, it's also a marker of bad. So this was always funny. I was in the late breaking clinical trial in the conference room when it was reported out at ACC. And, Shelley Wood, I know her from TCT. She's like, I'm chuckling at maybe HDL isn't actually good cholesterol. Maybe it's just okay cholesterol. That was the principal investigator reporting out their late breaking trial. And so I created this shirt, world's okayest lipoprotein, HDL. Maybe it's just too nerdy for you, but I am a lipidologist. So nutraceuticals, I'm asked this all the time by everyone. What are these? Are they helpful? Please don't call them over the counter. They are not over the counter. That is specific to something that used to be prescribed. It's been FDA approved. It was on the prescription side of the counter, on the side where the pharmacist was. Thus, it was behind that counter, and now it's been approved to be over the counter. Ibuprofen, Tylenol, or acetaminophen, Benadryl, right? Diphenhydramine. These were once prescriptive. They're still prescription, but they're also over the counter. They're FDA regulated. Off the shelf is what you should be calling nutraceuticals. They are not FDA regulated, at least not in the same manner. They go through the DSHEA Act. Yes, our own Orrin Hatch helped that, but you never required a prescription for those. They've never gone through an FDA process to receive an indication. So don't fall for the over-the-counter safety thing. It's just a nutraceutical. It's just off the shelf. Okay. So there's the over-the-counter products. This is just you can walk into any pharmacy and they have a bunch of off-the-shelf stuff that was never FDA approved, never have gone through clinical trials, and certainly are not regulated. So what does that mean for me when I talk about lipid therapies? And, people want to do garlic, they want to do cinnamon, they want to do, what about this red yeast rice? And this was an elegant study. The sports study looked at and ultimately enrolled 199 patients. 1,000 were screened. You can kind of see what the exclusions were. And they took rosuvastatin, a statin, at its lowest dose at 5 milligrams. It's almost lickable dose. And then placebo, fish oil, cinnamon, garlic, turmeric, plant sterols, and red yeast rice. And this was the result. Rosuvastatin, almost 40% reduction at its lowest dose of LDL cholesterol. And you're like, well, there looked like some benefit, with fish oil and cinnamon, kind of cross that line there. By the way, no crossing here. Garlic, turmeric, red yeast rice. And you're like, well, maybe that was beneficial. I'll point out that placebo was better than cinnamon, was better than garlic, was better than turmeric. But look at this. So this feels busy, but what happened is you can see the inclusion criteria, 40 to 75, LDL between 70 and 189. They had some risk, intermediate or borderline to almost high risk. And they did 30 days of these products. And this is what's called a waterfall list. This is the entire 25 individuals that were randomized to rosuvastatin. Every single person had an LDL cholesterol reduction. Now, while the average was 37%, some had like nearly 55. The lowest was at least 20%. Look at placebo. Placebo folks also got a benefit, but also did not. And everyone else has a waterfall plot that looks just like placebo. So again, there's placebo and here's red yeast rice. What that tells you is that this is why we do placebo-controlled trials, because people will have benefit if they think there's going to be benefit. And sometimes the lifestyle part that you add to it is what the benefit is. And this is why we want to look at different products matched against one another. And it's always helpful to do a placebo. This is just stark in my mind when you say, well, is it better than placebo? And I'd say, yes, rosuvastatin is better than placebo. Everything else looks just like a placebo waterfall plot. So as we kind of think of atherosclerosis, here's blood flow. And by the way, this is not judgment. If you want to do nutraceuticals, do nutraceuticals. Just understand the limitations and the lack of science that we've had in that space. So here is, an artery, any artery, and this is where lipids come in. They get underneath the single cell layer of endothelium. So it's not in the actual center of the artery, but it gets underneath this endothelial layer, and then it can cause calcification when it's there's injury. So I use a lot of calcium scans because calcium 0 looks like this, calcium 1 to 100 looks like this, 101 to 400 looks like this, and then 400 plus. And when you look at a Kaplan-Meier curve of 400, it lines up with people who had a heart attack. When they've had a STEMI, ST elevation MI, from time zero, should they survive it, and you follow them the next 10, 15 years, their event rate is about 20% in the next 10 years. Calcium zero is flat. It's not zero, it's flat though, and it stays about 1%. Calcium 400 lines right up with STEMI or ST elevation MI, which means these are all near misses until they're not. They're near misses in terms of atherosclerotic plaque rupture. They tend to heal and calcify until they don't. So blood pressure, it's important that normal is known. Less than 120 over 80, everything else ends up being either elevated or stage 1, stage 2 hypertension. So know your numbers, know your numbers. It's, know why you're at risk, because I would say you would not go, well, maybe you do. The pressure of water to your house, you might not worry about what the PSI is, but certainly you would know if someone hooked up the pressure to your home to the fire hydrant, which is way too much pressure. And just like your organs, your eyes, your heart, your kidneys don't like high pressure, your appliances would look somewhat like this. It would start to have, and this is kind of like an aneurysm that then blows, okay? Or the appliance itself will get damaged. So what's essential? I would argue pressure is essential. Hypertension is not. Here's low blood pressure. City turned down the pressure to your house, and so it doesn't do much. Maybe you stood up a little bit too long, you have a vasovagal moment, and down you go. Or on the other end, you have high pressure. And so this gal's like, yeah, this is great. I'm just going to not support that wand. And there you go. Okay. So assault with a deadly weapon. I found this at the DI, and I love the shirt so much I took a picture of it. Okay, so salt, where are we? Do we have to restrict much? This is the recommended, about 1,500 milligrams, which is, half to 3/4 teaspoons. You and I, as Americans, we're about 8,000 milligrams a day on average. And so, a piece of pizza is about 300 milligrams a slice. A can of soup that, as like tomato soup, is probably near 900 milligrams. We ingest a lot of salt. So probably we could eat a lot less salt. But here, drink alcohol. I don't drink, others do. There's this ongoing thing where in the past, I'll give you, granted, American Heart Association was like, yeah, 1 glass of red wine, that's helpful. We've since turned away from that. No alcohol is helpful, but it used to be, we'd say, well, less than a drink for women. And that, I still don't know what that means. Do you just kind of, cork the beer and just click, and then you take a sip and leave it? I'm not sure. I don't know how that works, but certainly if it's my Diet Mountain Dew, I will finish that. Okay, so patient perspectives. I am so aware. This is why patient shared decision-making, patient engagement, patient empowerment is so important to me, because this is just untenable to keep throwing meds at people. The cost is too high. And then the side effect profile. It doesn't happen with everyone, but when you start like prescribing things to help reduce the side effects to a medication that you're treating for this, it's problematic. And we have to understand that, okay? So I'm just going to reimagine medical care right now, the delivery and interaction. It's terrible. Healthcare 1.0 is not very nice to people. We as providers often, like, we assume, of course, you know where to park. Of course, you know how to get up to my clinic. Of course, you're going to get through the front desk and get through my reception staff and know how to call me and or get a hold of me. It's not very clear how all of that truly works. And it's different from clinic to clinic, hospital. So how do we kind of help empower folks? I will say, before I get carried away and become too paternalistic about technology, this always comes to mind. This is my wife reminding me to be nice. Let's see if this works.
Emma. Huh? Emma. Emma. Emma.
Okay, hopefully that's clear that sometimes technology isn't the answer. But in the event that it is the answer, we have great, thermometers that are, Bluetooth, or they connect. This is an old iPod. You probably, I don't know if you've even seen one, but this guy's got an iPod as well. But this is the near field Bluetooth, the way that we can really. I've got some engineers and machinists that they're meticulous. They all graph things and give me their blood pressure, their heart rate, their lipids from like 30 years ago, and they graph all of that. But it's cool to have technology to help us in this space. It doesn't solve everything, but it does leverage the convenience of these things. So, there's all sorts of devices, and I've, to one degree or another, implemented a lot of these in clinic, and a lot of them are FDA cleared for usage in direct to consumer. So they're cleared, they have at least some standard that they follow, and are pretty nifty and fairly accurate. So I would say this, in the end, I don't want to belabor it. I want to give time for Q&A, but continue to help others, but make sure your health is taken care of first. Think flight mask, right? Get that oxygen on first before you move anything else. Refill your reservoir. Know your personal risk. Know your numbers. And think about the essential 8. Start to implement those things. But give yourself grace. The essential 8 seem simple. They're not the easiest to implement if you haven't been. And if you're starting out, if you've never written a paper, how do you know how to do it, right? So give yourself grace. Start low, go slow, but start. And then consider the FIT principle if you're exercising: frequency, intensity, time, type. Get into it slowly. Technology is promising. I think it adds value. I think it really does, but it can be onerous as well. Don't be a slave to it. And I'll just stop there.
Thank you, Dr. Lee. That was awesome. I was mostly chatting with myself in the chat, so if you see stuff in there, it's primarily me just responding to yeah, I appreciated your influx of humor throughout that presentation. So thank you.
You're welcome.
Does anyone have any questions for Dr. Lee? You can drop it in the chat if you can't unmute, or you can unmute and ask your question.
Dr. Lee, what have you found to be the best way to motivate your patients?
Yeah. I think it depends, right, on which part you're talking about, and what their personal disease burden is, or their personal risk is. I lean into that. And of course, as I said, lifestyle is first and foremost. So I think the motivation is not the stick, it's the carrot. It's the carrot. When you first start and you say, why are we even here? Why are you here? Because you're paying for this and I want to make it worth your while. And I start with, let's just talk about risk in general, and then we'll get into your risk specifically. And then what are the ways that we can bend that risk if you're interested? And often when we've gone through that journey, it's like, wait, what can I do again? It sounds like I've got some risk. That's where you lean into it. They have to know the why before you can start like explaining the what's and the hows. You just have to know the why first. And then I see here, do you use health coaches in your clinic? Unfortunately, we've run out of health coaches, actually. Intermountain, I'm going to be glib, and I don't mean to, but we did have a Live Well program that has gone away. I love my health system. I love my people, but it's always funny that we took health care out of health care. So it's Intermountain Health. But I think that was poor choice, but who knows? We'll see what happens. But I don't have health coaches, and so I'm it. All of my patients get my cell phone, and I know it's like cringe. Really, yes, they do. And I answer texts all day long or in the evening. I tell them, look, I might not be able to answer you immediately, but I get to text. And I will do refills. I'll do, assessments, evaluations, and just give them data that way. So, and I see here, when treating hypertension, how long do you monitor at home before starting them on a medication? So that's very important. Look, there is no way that a poorly done blood pressure, and I'll admit to it, because these patients are walked straight back. They get this, oscillometric blood pressure cuff, and then we take their blood. It's so unfair. That is 1 minute of their life, and you're consigning them to something for 365 days or their entire life. So I make sure that they're engaged. Again, the whys, I explain that, and I say, look, this is the blood pressure issue, but I'm going to believe what you get at home, but you need to learn how to do your blood pressure measurements. And these are the key takeaways. If it's this, then you're at risk and we should do something. And they'll text me and say, yeah, I think that medication we talked about, let's just do that. So that's really the way that we come about it. And then lifestyle changes. If you go to the American Heart Association, the 2017 guidelines, there's a nice figure that gives you everything that's at least to date known to reduce blood pressure and how much it does it. Now, it's not additive. It's not cumulative. Sorry, it's not cumulative, but every single one of those may potentially reduce from 3 to up to 11 millimeters of mercury. So hopefully that's helpful. And then prefer measuring and treating LDL. Look at you. I'm going to leverage the lipid nerd in you as well. So for those of you that don't quite understand the nuance of this question, LDL cholesterol is an ApoB protein particle. So all of these atherogenic particles are ApoB100. That's the protein that surrounds cholesterol esters and triglycerides. The first one out of the gate is very large density lipoprotein. And then as it's kind of going around, it only lasts like 4 to 5 hours, because then this lipoprotein lipase enzyme cleaves off cholesterol esters and triglycerides, making it smaller. It's still an ApoB100. It just has less. So now it's intermediate density, and then it cleaves off some more, and then it's smaller. It's still an ApoB100, but now it's LDL cholesterol, low density instead of very large density. So I like to do ApoB because I think that's where we're moving. It's much more precise. It defines all of the atherogenic particles, not just the smallest version of it, which happens to be the one that causes atherogenesis. So I do both right now. All of our clinical trials are at thank you for putting that in there. All of our clinical trials are targeted towards LDL cholesterol, but many of the more contemporary trials have ApoB at the same time they did LDL cholesterol. So we can look and see as a secondary measure, but prospectively, what those ApoB targets should be. So yeah, if you get the opportunity, get an ApoB, Intermountain Health, they say that's, they allow that anyways, and Select Health will pay for that. So thank you for that question. I should print it. It's the okayest lipoprotein out there. People they assign too much to HDL cholesterol. It's not all that, I promise. Just like me, I'm not all that. But I sure make a big, razzle dazzle. Yeah, thank you. Thank you. Appreciate it, everyone.
Looks like we might be running out of questions. Are there any other questions for Dr. Lee? Dr. Lee, thank you so much for sharing your expertise and joining us this evening. It is much, much appreciated. Again, for those of you that attended, you should be getting a survey email later tonight or maybe tomorrow. Please complete that survey because it helps us with our future Peaks Con Ed activities and webinars. And we thank you all for joining, especially on an evening, and have a great rest of your night.
Thank you, everyone.
All right. Thank you so much.
Bye.